right. Yeah, thank you for the introduction. My name's Tom Wade. I'm the metabolic and bariatric surgery here for our program. Just a little bit about me. I grew up in Southern Illinois near St. Louis. I made it to Wisconsin for undergrad, went to Marquette, went to medical school in Chicago at Loyola University of Chicago, came back here for residency, went back to St. Louis for my bariatric surgery training, and then have been here for almost 10 years now. You see the rest of our team here on the slide. Most of us will be able to introduce ourselves as we go along. Next slide, please. So, as you know, obesity, it's a complex disease. We've been learning more and more about this recently. I know major advancements in medical therapy and understanding hormonal components of it. It comes down to genetics and your microbiome, your lifestyle, the lifestyle around you. There's certainly interpersonal structural components to the societies that we live in and the environments that we live in. So we know it's not sort of a straightforward problem, and it requires, I think, a team to approach it from all these different avenues, and that's what we're trying to provide here with our program. So we know that it's not a simple, straightforward, everybody has the same issue, eat more, move less sort of situation. The goal in our program is to approach everybody as an individual and help them get through their obesity issues. And this slide is really a little bit of a busy slide, but it just kind of points out how weight-related obesity issues can affect multiple parts of our health. So common things people think about, your cardiovascular health. So, high blood pressure, risks of cardiac events, stroke, certainly related to obesity. Other things that maybe we don't think as much, pulmonary sleep apnea is related, asthma is related. You have your metabolic component, which is certainly the primary goal when you treat obesity is the metabolic side of things. Type 2 diabetes responds very well to therapies. So we have issues with prediabetes, diabetes, high lipids or dyslipidemia, issues with fatty liver disease. Additionally, you'll see problems with mobility, increases in osteoarthritis, decrease in your ability to be active, increase in sort of joint muscle, general musculoskeletal pain. Other things that we don't talk about as much, people who have issues with urinary incontinence or stress incontinence is certainly highly associated with obesity as well. And then you can see the other side of things, psychosocial and reproductive issues are all components that we have to think about when it comes to the goals of treating obesity and metabolic conditions and the outcomes that we can achieve. And probably a piece of the puzzle that we don't talk about enough is there are several cancer that are obesity related. And so that it's not necessarily an immediate response that you'll note from treating this disease, but certainly a long-term benefit. Next, please. So here's my slide. We got there a little bit early. What about candidates for surgery? So our program, currently we are accepting patients between the ages of 18 and 64. One of the standard ways that we determine patients if they're eligible is through their BMI. And so we have guidelines, as you see here, for males, it's 35 to 55, and for females, it's 35 to 60. Certainly, if patients are on the edges of this, maybe they're a little bit higher in the BMI, we can enter them to the medical side of our program, get some success there, maybe get folks down into a range where surgery would be appropriate. And we have to be able to walk and be mobile. This is important just for your overall health to begin and afterwards your success. And then when we start looking at other comorbidities other than the ones we discussed, so if, patients who have got organ failure, maybe they've had a transplant, they've got what we would call significant cardiac or pulmonary disease. So, if not your usual hypertension type issues, but significant cardiac stuff that limits their ability to manage through surgery and recover. And again, certainly patients who are on a transplant list, that would be significant disease process. Those patients we don't currently enter into our program. There are programs that maybe would be able to, but we are currently not enrolling those type of patients. And then finally, as current status, we are only enrolling folks with commercial insurance. This is essentially because we are working through the program, learning how to get people into it, approved, have success, and long-term coverage for their therapies as well. So we are having success in that route. Next, we'll talk about the types of procedures. So there's two main bariatric surgical procedures that we would provide here, and that are the two most common in the United States. So the one that people typically think about is a gastric bypass. This is the older of the two procedures. It combines sort of a restrictive and malabsorption approach to weight loss. So the stomach is divided but not removed. So we create a small pouch, which you see it in this picture. It's essentially the size of a large egg. That pouch creates some of the restriction, and then we bring a piece of intestines up to attach to that pouch. So when you eat, they'll go to the small pouch, then down through that intestines. The stomach that is left in place, that part of the intestines comes around and sort of connects further down. And so the malabsorption component of this operation involves those two pieces of intestines that you have the food in one and the enzymes that break down food in the other. And after they meet, that's when you're able to start absorbing nutrients and calories. So there's a little bit of a malabsorption. Probably what's most important, actually, we've learned over the past few years is sort of the change in your hormones. You'll notice a dramatic decrease in sort of the hunger hormone that patients will have, or we all have. And that's probably the biggest driver of weight loss overall, but certainly the other two components help. We'll show you the other procedure, the sleeve gastrectomy, in a minute. The advantages of this procedure are that patients generally have a better resolution in their comorbid conditions, particularly diabetes. And if you have a lot of heartburn, this procedure is preferred because it sort of separates your stomach from your esophagus much. It's a really good heartburn operation. There are disadvantages. There's an increased risk of surgery in the future for a bowel obstruction, or what we call an internal hernia. And there's a slightly higher risk of vitamin deficiencies, although if you're in the program, you're following along, we monitor this. Weight loss is reported somewhere around 70% of your excess weight. And now we can talk about the other procedure. So the other procedure is the sleeve gastrectomy. This procedure is a little newer, not brand new, but newer than the bypass. It involves removing a significant portion of your stomach. 70 to 80% of your stomach is actually removed. You end up with sort of a longer, thin, banana-shaped stomach. This results in some restriction components. So you're obviously going to fill faster. You're going to feel that pressure, but no malabsorption. This also decreases that hunger hormone that we talked about. It'll help you just sort of decrease your desire to eat. The advantages of this operation, in the short term, it's a little bit faster operation, usually out of the hospital a little bit faster. There's a decreased risk of needing surgery in the future. That sort of internal hernia obstruction risk I talked about with the bypass is not there with this procedure, but it has its disadvantages. So less likely to resolve diabetes and some of the other comorbid conditions, including hypertension. It's not that it doesn't happen, it's just not quite as likely. And there's a risk of heartburn because you create a little bit of a high pressure stomach. There's a risk of increasing or developing heartburn. Some people will have their heartburn go away because of the weight loss, but there is a risk of it getting worse. There's a slightly lower weight loss profile with this as well, maybe 5 to 10% less weight loss. So it's not a large number, but it's certainly a little bit less. So what are our outcomes, or what are, it's not really our outcomes, these are literature-based outcomes. So large studies would tell us that there's good resolution of comorbid conditions. So type 2 diabetes can have up to a 92% rate of remission, so off of insulin, off of medications. Hypertension is 75%, sleep apnea even higher, close to 100% of folks with weight loss will get off of their CPAP machine. Your lipid profile, cholesterol will get better, and overall cardiovascular disease, kind of all comers with that includes dyslipidemia and hypertension and other cardiovascular issues also improve a significant amount. This is combining procedures, so it's not just one, but it certainly shows that bariatric surgery can have a dramatic effect on your overall health profile. And that's really shown in I think the most important part of this slide is the increase in life expectancy. So you take all comers, if they have surgery, don't have surgery, surgical patients it's a kind of a broad 3 to 9 year range, but safe to say life expectancy is certainly increased after these surgical procedures, which is a great outcome. Next. So this slide will be a little busy. We'll just go ahead and pull up the average weight loss outcomes. It's one of the things people like to talk about. And so a lot's been happening, thankfully, in bariatric and metabolic therapy over the past couple of years. So this slide shows you beginning lifestyle modifications that eat less, move more, about 2 to 8% weight loss, not necessarily sustained, but it exists. And then you have a series of other medications. And essentially, the way to evaluate this is on the left side are medications that essentially attack one angle of weight issues. And they have weight losses, 5, 8, maybe up to 10% in studies. And then as we move across the table, you start to see some of the newer medications that maybe have a couple of different mechanisms that they approach as far as weight loss. And those start to get higher, closer to the 12, 15, up to 20% weight loss. These are great outcomes that they've been able to obtain. But even at this rate, they're still below what you would see with bariatric surgery. So a sleeve gastrectomy, 20 to 35%, and then the Roux-en-Y gastric bypass, right there around 35%. So it's a little bit of a busy slide. The idea is just essentially to tell you that there are a lot of options. The surgical options are still the ones that have achieved the highest success with weight loss. Again, another slide related to weight loss. This one just shows you mainly the difference between the two options. So the sleeve gastrectomy and the Roux-en-Y bypass. Again, kind of what we talked about earlier, there's a slightly higher percentage of weight loss with the bypass procedure. That being said, the sleeve gastrectomy has done quite well. It's over 20%. And the other important thing I think on this slide is if you notice, it's a 7-year follow-up slide. So there's a decent amount of data, and it shows rapid weight loss at the beginning, as we would expect, often a little bit of an increase, and then this nice, what we would call plateau, where people do well maintaining their weight loss over a long period of time. 7 years is a pretty nice follow-up to show that weight loss is maintained. So what's the safety profile? It's good to know. Obviously, surgery is a scary thing to go through. That being said, this is safe surgery. They call it a composite complication rate. So that's taking small complications, big complications, and its rate is about 3.4%, which is on par with other surgeries you may be familiar with, like getting your gallbladder out, getting your appendix out, or having a knee replacement. Mortality rate, very low, 0.3%. And so again, on par with other surgeries that are common and safe. So conclusion to my portion is that obesity is a complex disease process that, in our opinion, requires a comprehensive approach. So we had the slide earlier that showed, myself, we've got 2 nurse practitioners, you're going to have behavioral health, you're going to have coordinator, you're going to have a lot of resources in our program to attack this really complex disease. And we understand that people will come at it from both different etiologies and different backgrounds, and our goal is to meet people where they are and kind of work through this process. We view ourselves as really trying to be a partner in this. Surgery, I'm the surgeon of the group. It's a powerful tool. We think it's useful tool to have in our toolbox, but we understand that there are lots of options out there. And we're not a one-size-fits-all sort of program. So it is here to be considered and reviewed with by patients, but not the only option that we would provide or talk about or utilize. We know that this process is a lifelong process for everybody. We're up at the beginning when you meet us and we get to the program and operate and have good success, but you're gonna need to have lifestyle changes going forward, and we're here to help with that. We would want to have long-term follow-up and a long-term relationship. So I guess in the end, we're excited to be here to help. We've got lots of tools. Surgery is one of them, and we're happy to meet with you where you are. And that is my part.
Excellent. Thank you, Dr. Wade. I'm Andrea Von Helms. I'm the bariatric program coordinator, and I'm also the dietitian. So I'll share with you a little bit more about our specific program and about the pathway to surgery and what that looks like. So we are located at Waukesha Memorial Hospital. We're in the professional office building. We do a combination of visits that are in person and virtual sessions. We do both group and individual sessions too. The surgeries are also going to be performed here. You'll be staying on a dedicated floor with specially trained staff during your recovery. Okay. And as Dr. Wade had mentioned before, we really are a team, a multidisciplinary team, meaning we have different educational backgrounds, but we come together to help you in the best way we can from all of these different angles. So that you have a behavioral health component, medical and surgical component, and also a nutrition component. So as you enter our program, or come into our program, I know this looks like a really busy slide. I'll highlight parts that are important. So you'll come into our program with a referral, perhaps from your primary care provider or any other pro-health provider, and we'll check your medical history and verify your insurance benefits to see if bariatric surgery is a covered benefit for you. Insurance does vary quite a bit from carrier to carrier and even among plans, but we do have experts who work with us and they handle the entire insurance process on your behalf. And I will share a little bit more about the insurance process just a moment later. So if all of that looks good, we'll schedule you to meet with our surgeon, Dr. Wade, for a consult. Before that visit, you'll do a really quick orientation, and then you'll meet with Dr. Wade to talk about the surgical options, safety, the benefits, and the risks specific to you. And immediately after that appointment, we'll talk again, me and you, to go through what your specific insurance coverage looks like and what you might need to do to be well optimized before surgery. Okay. So you'll have appointments with the team, including of the nurse practitioner, the dietitian, and the behavioral health therapist. And we just get you ready for surgery and the lifestyle that follows after. We'll do a series of virtual classes so you can learn about the nutrition and nutrition plan and start making some nutrition changes just to help your transition to life after surgery. And then meet with the behavioral health therapist at least once for a consultation. And the purpose of meeting is that so we as a team can learn more about you, about your strengths and possible barriers that you might have. And then when we know about them earlier, we can help you a little bit better yet. At the same time, you'll be working towards medical optimization, which might include getting a sleep study, maybe working with a specialist for imaging, getting our blood sugars in a healthier spot, or quitting smoking. If your insurance requires a medical weight management program, you can also have additional appointments with the dietitian, nurse practitioner, and behavioral health therapist. So once all of those preoperative steps are complete, your case can get submitted to your insurance for prior authorization. They take a little bit to respond, but when we come back with an approved, then we get to reach the next phase, where you'll meet with Dr. Wade once more. You meet with your primary care physician for history and physical, do some lab work, attend another pre-op class with our nurse practitioner. It really covers everything you need to know from that point through your first couple of weeks of surgery. Okay, and then I had mentioned before, insurance has some requirements, and then we as a program also have some requirements. Thankfully, a lot of them do overlap. So our goal is just to help you be optimized for surgery, being really well prepared for it and the lifestyle thereafter. So as our program guideline, we ask that you do attend your appointments so that we are able to help you. From a medical standpoint, what we're looking for is that we're able to not use any nicotine or any type of illicit drugs. They just put you at greater risk for surgical complications. If you do have a medical history of diabetes, your hemoglobin A1C level, that's that score that averages your blood sugar over 3 months, will need to be less than 9. We also see that a high A1C is linked to poor healing after surgery and wounds, but this is something that we can help you with before surgery. If you were to be diagnosed with obstructive sleep apnea, or you're recommended to use a CPAP machine when you're sleeping, you just need to show that you're using it. We do know that sleep does play an important role in weight loss. So without having really good restful sleep, it can put your health and your weight loss in jeopardy, even with metabolic and bariatric surgery. Right. And I mentioned earlier, you'll meet with the dietitian 3 times. We'll have a few classes where you'll learn all about the nutrition for after surgery, and you'll meet with that behavioral health therapist at least once until you both agree that you're well prepared or optimized from a behavioral health perspective. Right. Now, insurance companies, they have their own specific guidelines. Some are very vague and require very little, and others are really specific and they might require more. Often coverage is based on BMI groups. So for example, the requirements for someone who has a BMI, that's that height to weight ratio of 35 to 40, that might be different than those who have a BMI of 40 or above. But most insurances do look for a weight history of like 2 to 5 years that do show a long-term history of obesity. And they do want to hear about your previous weight loss attempts. They want to know that metabolic and bariatric surgery isn't your first try at losing weight. Some insurance companies do require this medical weight management program. These are overseen by medical professionals and they've got notes documenting each visit. Some companies are pretty vague about how long, so others are a little bit more specific and they say 3 months or 6 months. Very few I've seen require 24 months, but we can do all of these visits with you too. Okay. Some insurance companies might also require a physical therapy evaluation that might be based on a BMI or that's in conjunction with a medical weight management program. Our outpatient physical therapy clinics offer several locations, and each has a provider who specializes in caring for people in all body sizes. So we do have experts working with us who handle the entire insurance process on your behalf, but you may also call your insurance company to learn about what is or isn't covered and what criteria are needed for you to be a good surgical candidate. So if you were to call, these would be the top 4 questions to ask. First, is metabolic and bariatric surgery, sometimes people refer to this as weight loss surgery, a covered benefit? Is it for morbid obesity, which is a BMI more than 40, or for severe obesity of a BMI of 35 to 40? It is helpful if you know your BMI before giving them a call. Ask about any qualifying comorbidities. That means any diseases or health conditions that you might have to get coverage. Maybe if your BMI is around 35, you might also need a diagnosis of high blood pressure or diabetes or sleep apnea. Okay. Most often, if your BMI is more than 40, no other comorbid conditions are required. And then ask, can I have my surgery done at Pro Healthcare? So if you're already receiving care here, we are probably in network. Some insurances require surgery to be performed at a center of excellence. As a newer program, this is an accreditation that we're actively working towards, but we do not have yet. And then do ask about any other requirements for coverage. Do I need to participate in a medical weight management program? If so, how long? Is there anything else that I need to know or anything else that you can tell me? And like I mentioned before, we do have experts working with us who handle the entire insurance process on your behalf. However, it just never hurts to call and ask these questions yourself. Once you do have metabolic bariatric surgery, you will always be a metabolic and bariatric surgery patient. So you'll meet with the multidisciplinary team most frequently in your first year, and then we do work with you long-term thereafter. But standard follow-up visits are at 2 and 6 weeks, months 3, 6, 9, and 12. And then we do monitor your labs. Dr. Wade did mention there's a risk for vitamin and mineral deficiencies. We keep a close eye on those, right? The nurse practitioner is also willing to help with managing medications for obesity-related diseases as you're losing weight quickly. You might be able to go off some of medications, and we can keep an eye on some of those too. All right, we'll meet with you at least twice in the second year and then twice again in the third year and annually thereafter. And you're always welcome to come back for additional appointments if and when you need them. So yes, we are part of your support team, but there's more that we want to help you with. So we give you a number of support tools too. So some of the ones you can kind of more or less physically hold are our bariatric patient education binder. It's got everything in there that you need to know about how to stay healthy and have a successful weight loss journey. We have a metabolic and bariatric surgery support group with people who have had or are also having bariatric surgery, and it'll always be free to attend. You have group sessions and classes, and then more appointments as needed. Some patients also benefit from additional obesity medications in combination with metabolic and bariatric surgery. So if needed, we would be willing to prescribe and manage those too. I do want to put in a little bit of a plug for our MBS support groups. These are held virtually. You are very welcome to attend, whether you're having bariatric surgery here or still thinking about it. We meet on the second Monday of the month from 5:30 until 6:30 p.m. And to register for these events, you can go to our ProHealth website, classes and events, hit support groups, and search for metabolic and bariatric surgery support group. So if you feel like you're ready to start, you can request a referral from any ProHealthcare provider, or your primary care provider can fax it over if you're from seeing someone from another health group. You can also reach out on our website, prohealthcare.org/weight loss surgery, and click request a consultation, and then I could reach out on your behalf. And that concludes my part of what I have to share with you, and I am looking forward to your questions. So I will let my colleagues also introduce themselves, and all right, take it away. Thank you.
I can start by introducing myself to the group and to the people attending. My name is Elizabeth. I am the behavioral health therapist on the weight management team and on the bariatric surgery team. I'm really honored to be a part of this group and helping people through this whole journey.
And then I will introduce myself. So I am Emily Pearson. I am the nurse practitioner for both our medical weight management and for our metabolic and bariatric surgery program. Like Andrea had mentioned when she was laying out the program, I help with getting you optimized for surgery, whatever that may be, and then just see you preoperatively and postoperatively and try to continue to help you however I can.
All right, well, thank you, ladies. So we'll open it up now. I don't know, there's a few people on the call. If you're interested, you can use that chat feature to ask questions. Otherwise, we have some questions too that we know many people ask, and we'll pose to the group if you're not able to think of any at the time. So take your time. You can kind of think and enter any questions in the chat box. But in the meantime, I can ask a few questions that I have here. So this one's for Dr. Wade. Why would you recommend one surgery versus another?
Yeah, that's a good question. So there are a few things that would kind of drive you to the gastric bypass. And so I think patients who have insulin dependent diabetes are probably better off with the bypass. If you have really significant reflux going into surgery, a bypass is probably a better option just because of that risk of worsening reflux with the sleeve. I think patients that are a little lower BMI, maybe don't have those other comorbid conditions, a sleeve might be a better option. Maybe not better, but maybe a little more appropriate, just because a little quicker recovery and lower long-term preoperative risk profile. So it's mostly from a medical standpoint based around comorbid conditions going in, and then certainly patients, familiarity and preference with it will obviously be a big part.
Great, thank you. Again, feel free to put your questions in there, but I do have a question for Andrea. So what vitamins will I need?
Oh, yes. Okay. So I mentioned before, there is the risk for vitamin and mineral deficiencies. So there is a bariatric multivitamin. There's many companies that make it. Most patients purchase it online, but it's specially formulated to take into account how the body has changed and how that impacts our vitamin and mineral absorption. It also takes into account the fact that we're not eating nearly as much after surgery. So you'll start with a bariatric multivitamin. Most patients also will need a calcium supplement, which you would end up taking separately. So generally it's just those two. If you have a deficiency, perhaps in vitamin B12 or iron, they tend to be the most common, then we'll supplement extras of those for a shorter amount of time until it's back to normal.
Great, thank you. And then another question for you. You mentioned diet changes after and potentially leading up to it. Can you just go into more detail and talk about how that diet change looks?
Absolutely. So we're going to spend, once we get to work together, nearly 3 hours talking about this, and I like to go into the why for all of it. But after surgery, your stomach is pretty swollen from getting cut up, and it's a small stomach pouch. So instead of going back into a typical normal eating pattern, we work our way towards it. You also can't eat a whole lot at once, so we have to prioritize what's the most important nutrition. And we focus a lot on protein because it's important for your healing and for helping you also feel satiated from one meal to the next. So we'll focus on protein after surgery. You'll start with liquids, go to pureed texture, minced and moist for a few weeks, and then we go into solid. As you're healing, you're able to eat a little bit more. So we'll eat protein foods first, produce like fruits and vegetables are second, and then starches are last.
Thank you, very helpful. All right, then I have a question for Elizabeth. Since you talk about bariatric surgery having such a good amount of weight loss, how does the behavioral health therapist help with this?
Well, I am a part of the pre-surgery and post-surgery team here. So before surgery, we would meet, we would talk about things like how's the stress in your life? How have you typically managed stress before? Change is hard, change is challenging, and I can help be a part of making that a little easier, making it a little less stressful, a little less uncomfortable than it has to be, right? And then, of course, after surgery, it's more change, right? It's different habits, it's different ways of managing things like social events, family get-togethers. And I'm here to be a helpful part of the team to support people through transformation, through change, through roadblocks that come up, challenges, things like that. And, like I like to say, behavioral health is a part of all corners of healthcare, including bariatric surgery.
Thank you. All right, another question. This one's for Emily. So if I started taking a newer weight loss medication, can I continue to take this and have bariatric surgery?
Yeah, and that's a really good question. And, that's going to be something we're going to be seeing more and more because there is, a definite increase in medical management of obesity, even prior to someone considering bariatric surgery. So it's dependent on the medication and what surgery the patient is having too. So, we would talk about those options before surgery. Because again, I'm seeing you prior to surgery to get you medically optimized. And then I have follow-ups with you after surgery. So as far as continuing weight management medications, we would talk about your options based on the medication that you're taking. And then if we need to adjust other medications that are not weight medication, so for example, your blood pressure medication, those are things that we eventually, hopefully, will be able to decrease over time as your blood pressure improves or your diabetes improves, so adjusting your diabetes medication. So those are all things that I address at my follow-up visits.
All right, thanks, Emily.
And I
And then,
will mention
yeah,
also that I have heard from patients post-surgery who find that really satisfying to start to cut down on their doses of blood pressure medication, cholesterol medication, diabetes, all of that. And eventually, hopefully get off of all of those. Everybody's a little different, but patients have talked about how satisfying that is for them.
awesome, thank you. And then the last question I have here, so how painful is this and how much pain could a person expect? And this one's for Dr. Wade.
So, pain's obviously a little bit of a personal experience. We do generally almost always perform the surgery with small incisions using the surgical robot to help us maneuver inside the abdomen through small incisions that generally don't cause, too much pain. There are two areas we will put suture often in the muscle to help avoid a hernia. So you'll notice some discomfort the first few days, maybe even up to a couple of weeks, but it's not generally pain that is restricting. So we get patients out of bed walking around the night of surgery. We expect patients to be pretty close to their baseline mobility when they go home. You'll notice you had surgery, you'll have some discomfort, but it's managed and manageable with pain medicine. And it varies. Some patients go home and don't take any more pain medicine, and some patients need it for a couple of days. But in general, we would not expect pain prescriptions for more than 2 or 3 days. So it's a pretty short-term issue where you would have enough discomfort you would even want to take medication. But obviously there's some pain from surgery, but I think it's less. In general, it's less than people think it's going to be when they go in.
All right, thanks, Dr. Wade. And I know there's nothing in the chat, but I'll give you this opportunity since I know some people have called in. If you'd like to come off of mute, please feel free. We would love to hear your questions and help get you those answers since we have such a great group on board here to help with that. I'll give you a minute if you want to come off of mute if you called in. I know it's a lot of good information, so you're probably processing, but we're happy to answer any questions. No? All right, well then I'll turn it over to you, Andrea, or the team, if you have any kind of final thoughts or things you'd like to share with those who are tuned in today.
I'll go first. I just wanted to say thank you for everybody taking the time to be on the call, both from program and certainly our call-in folks. It's a big decision and thought process. We just want to reiterate that we're here to help. If you aren't sure if you want to have surgery, or if you know you want to have surgery, or if you say, I don't want to have surgery, I want to talk to people from the medical side of things, all of these are options that we are happy to work with you on. Thank you for your time.